Welcome to the Mayo Clinic Ophthalmology Podcast, brought to you by Mayo Clinic. I'm your co-host, Dr. Brittany Scruggs.
And I'm your co-host, Dr. Eric Bothan. We are here to bring you the latest and greatest in ophthalmology, medicine, and more. Dr. Beth Kangas is the Executive Director of the Zumbro Valley Medical Society and Street Medicine Program. Tune in to this podcast to hear how her work is bringing compassionate, community-based care directly to those who need it most.
Dr. Beth Kangas is a medical and cultural anthropologist and the executive director of the Zumbro Valley Medical Society, or ZVMS, representing over 3,000 physicians and trainees in Southeast Minnesota. With a PhD from the University of Arizona and 2-year experience in Yemen, where she conducted research on healthcare utilization, she brings a culturally grounded perspective to healthcare systems and access. She is the co-founder and director of ZVMS Street Medicine, a program that delivers care directly to individuals experiencing homelessness through community clinics and outreach. She also co-founded The Table, team of advisors bringing lived experience of homelessness who actively shape programs and policy in our region. Through her leadership, interdisciplinary collaborations have expanded care in eye health, dermatology, cardiovascular medicine, foot care, and primary care, while also transforming medical education by integrating real-world, community-based experiences. She is the recipient of the 2025 Mayor's Medal of Honor for Human Services, recognizing her profound impact on health equity and compassionate care delivery. Welcome, Dr. Kangas.
Thank you very much. Thank you all. I'm excited to be here.
Yeah, I'm excited you're here too. So for the listeners, Dr. Kangas and I are partners in the street medicine program. And honestly, she has transformed our community. And the award you got this year is just exactly, you're the right person for that award. And we're very thankful to have you.
Oh, thank you.
Yeah. So maybe this is not correct, but Eric, correct me if I'm wrong. This is the first anthropologist we've had on the podcast. I think so too.
I'm excited to learn something.
I want to know more about this. So what does it mean to be an anthropologist? Tell me about your background and how did this lead to you being the director of a medical society?
Sure. Yeah. Thank you. So it's not obvious then?
Not obvious.
Okay. So how I came to anthropology first is when I was starting graduate school, I had just come back from Pakistan, where I worked for 3 years with refugees from Afghanistan. And prior to that, I had taught English in Japan for a year. And as an undergrad, I had done an internship in a village in Egypt. And so when I was considering a discipline for my graduate program, anthropology, cultural anthropology, was the discipline that understands that there are many ways of being human, many ways of doing things, and comes at that diversity with curiosity of let's try to understand things from an insider's perspective rather than judging it from the perspective of an outsider. And so, and medical anthropology, we look at the people's understandings of the body and how it works and what makes people sick and what makes them get better. We look at doctor-patient interaction. And we look at factors that influence who gets sick and how they get better. And
So I certainly have grown to appreciate you have a wealth of experience, obviously here in Rochester, but also internationally as you're sharing. For our listeners, what population do you serve with your care here in Rochester?
Yeah, so as the executive director of Zumbro Valley Medical Society, I have the opportunity to be a bridge between the medical community and then the local community. And 6 years ago, we started a street medicine program, and that brings medical care out of traditional clinical settings to people experiencing homelessness. So that's a population that that's where we've done a lot of our work.
It's a beautiful thing to think about bringing healthcare to where they are and where their needs are. Can you talk about why it's hard for certain individuals in certain communities to come into traditional healthcare homes? I mean, we're here in the shadows of the Mayo Clinic. What barriers do you see for an individual who is without a home currently to have access to our current clinics?
We say that people experiencing homelessness have a time horizon of about 24 hours because they're thinking about where am I going to stay tonight. And so when you're making an appointment for somebody a week from now, a month from now, 2 months from now, that's way beyond the 24-hour time horizon. So that's one thing. To make and keep appointments is hard. You need a phone that works. You need a place to charge your phone. If you do have a phone, you need a place to charge it where you can stay next to that charging phone and keep it safe. And then finally, when somebody makes an appointment and is able to keep it, they might experience negative reception after they've tried so hard. If they are camping, they've left their tent and their belongings with some concern about, is it going to be safe? Will it still be there when I come back? And so they're making it into the hospital or into the doctor's appointment. But a lot has happened before they arrive in your clinic, and a lot will happen when they leave your clinic. That just has so much of life circumstances that we don't usually factor in when.
Thank you for sharing that. I will admit, even a couple of those little points, you just realize I wouldn't have ever thought of that. So you're the focus to the street medicine program as you serve in leading is to bring healthcare to that community where they are accessible and available.
Yeah, let's talk about the logistics. So street medicine program, you have people who need medicine, need care, maybe need medication, need screening, not just with eyes, but everything, blood pressure and foot care and their diabetic care. So how does this look like? What are the logistics? You said this program started 6 years ago. So what is the program? Who are the volunteers? Walk us through the logistics. Let's start with that, the basics.
Sure. So in communities with larger populations of people experiencing homelessness and larger encampments, our street medicine colleagues are going into camps and going tent to tent or area to area and checking on people. Of course, building relationships, that is the very first thing, because there is a lot of mistrust. And unlike a patient coming into your office, and you can start with what brings you in today, if we're going to them, you can't say what brings you in today. And so it's really trying to gain rapport, build trust. Our population is smaller, and so we try to provide care through street rounds when we can, instead of hospital rounds, street rounds. And so we've had an emergency medicine physician going out with county social workers to try to identify people and build that relationship and provide care that way. Because we have a smaller population, it makes sense for our community to hold pop-up clinics. And so we started with a foot care clinic at a day shelter because people are on their feet so often. And we soaked feet and then had people check out their feet. And again, it's really about, because we're bringing medical care to people, instead of them coming in, then it's gaining that trust, and also having our medical student and physician volunteers become familiar and relax themselves in being outside of a traditional clinical setting. And so foot care clinic, and then we were blessed with an eye care clinic when you came to the foot care clinic and said that you want to do this for eye care. And so we started also at a day center, at the day shelter.
Doing dilated exams in a closet. Yeah, I remember that.
Yes, yeah. In the boiler room, you were doing pupillary somethings. And then we realized that we need a larger space. So now we hold Eyecare clinics in a local church here, all over it, actually, in the lobby and many of the rooms.
We take over the entire church.
Yeah.
Can you speak a little bit to the public health need and specifically vision care in this population? How important is it for them to have not only screenings, but also just good vision? Like, how does this impact their overall health, but also their quality of life?
Yeah.
And you've met people, you've heard their stories, and now that we've had several years of these clinics, share with us, what is the impact and the need here?
Yeah, to be able to see. Yes, yeah. And then not only to be able to see, but also to hold on to your glasses. So if you imagine you don't have you're moving from day shelter to night shelter and back to the day shelter. If you are somebody who uses shelters or in a camp or couch hopping or whatever the type of housing instability is. So hard to hold on to glasses, hard to keep them. Then, vision. I'm trying to think of different stories about glasses. None come to mind, so maybe we can. Another question.
So many locations have care outreaches, and I think of in our local community, and certainly we're speaking to this. I know up in the Minneapolis-St. Paul area, there are similar models. I would imagine across the country, different locations and different groups reach out in this way. And critically important, compassionate work. But as you do it, and for people that have not volunteered or not been involved, what would you say that surprises you the most in being there in the clinic, boots on the ground, working with this population?
What would you say is what stands out?
What's the feeling that can capture what it feels like when you drive away at the end of the day?
So I'll start. So just for perspective, going back to the logistics and what are we actually doing? So in the eye clinic, we have 13 stations, and these stations are set up where the patients get triaged and we understand their need, right? That's the first thing. Do you need glasses? Do you need reading glasses? Do you need distance glasses? Do you need a comprehensive eye exam? What is your medical history that would maybe increase the need for a comprehensive eye exam, and we can help them understand the needs? So that's number one. And if they just need reading glasses, we have all of the reading glasses they can go and pick up and then leave, right? But for a lot of patients, the vast majority, I think it's 80-something% of patients, they want to do everything because potentially they haven't ever seen an eye doctor, or definitely not in the last 10 years. And so the other stations would be visual acuity, pressure check, color plates, refraction, and so we do automated refraction, manifest refraction, dilated exams. We can talk a little bit about the equipments and resources and how you kind of get to this level, but they need glasses, and so kind of partnering with these different foundations. We've partnered with Essilor Foundation, where we can give these patients the glasses they need free of charge, which is amazing. But then also, this isn't just about giving eye care, right? It's about building rapport and about trust. And so in addition to just the eye clinic stations, we also have social work. The social work team talks about housing and talks about food security, talks about job applications, things that potentially are very much needed. Yep. And then we have the low vision team. The state services for the blind in Minnesota come and, share their resources with us. And then check out, sometimes we give boots because it's winter and they need some shoes, right? Very practical. Mm-hmm. So you leave feeling very tired. I would say this is the number one thing, because sometimes we see 200 patients in a 3-hour period. But you also feel like I just did something for my community in a way that's like very impactful. That's how I feel.
Yes.
And then also the second part, which I would love to hear your thoughts on, is medical education.
Yeah,
I think we
definitely.
all know that eye care, ophthalmology in general, is not well taught in medical school. And even if it's taught in a lecture, it doesn't lead to like being able to apply it in a clinical setting, because it's very scary to apply ophthalmology when you're a medical student. So the med students are the volunteers here, right? They're manning the stations, they're doing the acuity checks, they're doing the pressure checks. They are really in every station, understanding the eye. So from a
Yes.
medical education standpoint, the program you have helped co-found and you're developing, both rural medicine elective and street medicine elective, is changing medical school education here. And it is actually generated ophthalmologists,
Yeah.
which I think is huge.
Yeah, yeah.
So
it's
thank you.
exciting. It's exciting. Yeah.
And I'm curious what you've heard from the students and how you've developed this curriculum and program and elective, barriers, excitements, anything you can share.
Yeah. So for both dermatology, because we have a dermatology clinic, and that's also not taught, I guess it's not a regular part of the traditional curriculum, and ophthalmology, but it is on STEP, the exam. And so people have said the dermatology that I knew for STEP, I had learned at the dermatology training. Ophthalmology, I don't know its place in STEP, but that I think with ophthalmology, or our eye care clinic in general, because it is so clear and so transformative, you don't see and then you do see, that is satisfying for first-year medical students. We start our street medicine elective here, our selective, our optional elective, is mainly for first-year medical students, and we have 60 to 70% of the first-year medical school class taking the street medicine selective. And we start in August, right when they've arrived, and finish around, we culminate with the Eyecare clinic. That's exciting because medical students come in, they have chosen medicine to make an impact, and in their first year of medical school, they get PowerPoints of science, is what they've said. So not at all connected to the people that they want to serve. And through street medicine, they get to, and now through rural medicine, since we're providing care in our rural communities, they get to see it. And then when it's eye care and vision, they can see really, again, the changes that can take place in a person's life.
So medical students here at Mayo, it's part of their curriculum. And
yeah.
As you put this together, when you think about what's the most important message you want them to have? I mean, it's wonderful they're actually getting tangible patient care experiences so early. But is there what is the thought of opening up an experience for them? Because I would say a lot of people go through all of residency and don't have an experience like you're sharing.
Yeah.
It's not traditional, right?
No, exactly.
Not
So
at all.
what's your sense of what they gain from having this training and this experience?
Yeah, so for the street medicine selective, I think it was in year 2, we thought this is doing something, but we want to find out what it is doing. And so we did a qualitative study, asking around 25 students what was the impact of their street medicine training on their clinical sort of practice or anticipated clinical practice. And what we learned was seeing the person before the patient, so seeing the individual and their life circumstances before seeing their diagnosis or seeing their condition. That stood out as a lesson, which they can apply to anybody, right? Any patient population, anybody, that there is a person behind the patient. And then the effectiveness of listening. So they thought, often in their interview responses, they said, as a first-year medical student, I thought I can't really do anything. But then I learned the power of listening, and that I had the time to be able to do that, and what a difference it makes just to be able to sit and listen to somebody. And that was a role that they could have, and we would hope they would keep that role when they become the wonderful physicians that they will be.
And I don't know, I'd like you to expand on this table concept. Even in the introduction, it was describing, I guess, a little bit of a listening skill. As you're describing, kind of listening to their needs and their voices. But can you explain what that is and just how that lived experience is so critical?
Yes, yeah, I'd love to. So 2 years ago, a colleague and I co-founded the team of advisors bringing lived experience. The table has as a tagline, we didn't just want to be given a seat at the table, so we went ahead and created the table. So it is a chance for lived experience of homelessness or housing precarity to lead. And not in a community advisory board approach that is more common, where you might think, I have an idea, let me go collect the opinion and then I'll continue to do things or modify what I was planning on doing. The team of advisors bringing lived experience is a collective of about 15 people with lived experience who are paid for their participation in weekly meetings in order to provide input on policies, programs, procedures in Olmsted County and really promote community integration. So we want to be involved. Our first major activity was a community cookout where we served mac and cheese because mac and cheese is common in little food pantries in a way and a common donation item, but very hard to make when you're on the street. There's no butter, no milk, no fire, or heat. So we did our community cookout, and that also, so we wanted to change who gets to serve and who is served. So usually people experiencing homelessness they are the ones that are served meals, but we wanted to flip that, invite the whole community in to eat together.
And oftentimes the table and the street medicine program overlap, right?
Yes.
A lot of community members who are a part of the table also are volunteers or even share their lived experience with medical students.
Yeah.
So maybe share like the impact of that and kind of the overlap and how medical students have engaged with community members in that way.
Yeah. So for each of our community clinics, we do have the trainings the week of, right before the clinic. And we now try to have a table member come to the clinics to provide context on the significance of these clinics and how to gain rapport, how to approach people, what to do if you feel like you've made a mistake and sort of flubbed the interaction, like how to handle that. So hearing directly from somebody is, very helpful.
I would say they've also been amazing, like not only volunteers, but leaders in like organizing the clinics, right? And figuring out which ones work together logistically and the flow of the clinic and how does this make sense for the community members who are about to engage in this clinic workflow. I know I have learned a lot from partnering with them, and it's been really beautiful. So, yeah.
We have so now when we create a new clinic, we invite the leaders to come to the table. We realized the need for that because in our dermatology clinic, we were hearing things like the instructions like stay off your feet, make sure to change your shoes, have your socks be dry. And these weren't practical things for people's life circumstances. So we invited the leaders, a consultant and a medical student, to come to the table to talk about hygiene, the circumstances, And the first thing that a table member said was, when I was on the street, when I wanted to wash, I would find a single stall bathroom with a lock on the door and wash out of the sink. So instantly, you could tell that your typical dermatology instructions that people had been rattling off weren't going to work. And so then together, people can really figure out, this is my medical knowledge, this is what I would say is the ideal, tell me about your life circumstances, and then we'll work together to find a way to use a medicated shampoo or to use something. For our heart clinic, when we were planning that, we took the intake form to the table, and they said, well, these questions about drug use, when you have them at the top of the form, I'm not going to tell you that. I don't know who you are. I don't know if you're going to tell my probation officer or law enforcement. I'm not going to tell you. But if you move it down in the assessment and planning section
And build rapport.
I will know that the reason you're asking me those questions is because of my heart health, and you are concerned for my heart health, then I will tell you.
Wonderful. I'm sure from an eye exam perspective, you have to adapt equipment and testing in a way that is appropriate for your setting. We can't bring the slit lamps out there in the same way that we might have in the clinic, but I understand you have an example of a tool you use in refraction.
Yes.
And just so share with us kind of how you need to adapt an eye exam. Brittany, you can comment on this too, but then I'm excited to kind of see this novel way of measuring our refractions for patients.
And just for context, so this would be done in rural medicine, or it could be done in a encampment, or if you're going under a bridge, or if you're doing street rounds, right? You could just take this little kit with you. And for those who are just listening, it's literally a little kit. It looks like a little lunch box. And then there's essentially a trial frame.
Let's try it.
Yeah, we can try it for those who are watching.
And we learned about this from our Street Medicine Phoenix colleagues. So that's how they provide care, because they don't have the eye care clinics, the pop-up eye care clinics that we do twice a year.
Yeah.
Okay, so you're going to put this, you're going to narrate for
All right, I'll try to be the doctor,
Yes.
the volunteer, medical student.
I'll pretend like I'm a patient. I'm struggling with my vision. I haven't seen an eye doctor. I haven't been screened, but I know that I can't see in the distance. So I'm wearing these glasses, and they have essentially these vertical bars that can be adjusted very easily to figure out where my sweet spot is.
Yep.
Like, oh, okay, that's clear here.
So there's a dial on each side that dials the optics up or down. So let's just try this. Now I assume normally you'd cover one eye, but I'm going to ask Brittany here to cover her left eye.
Okay.
And looking out of the right eye, I want you to tell me as I turn this dial if it gets better or worse.
Yeah. Worse.
That's worse. Okay, let me go back the other direction. Is this getting better?
Yeah.
Okay.
Yeah, that was good.
And let me keep going. You tell me when it's clear looking at distance.
Yeah, that's much better.
Okay, I'm going to go a little further, and you tell
Yeah,
me
it's
if it's
even better.
No, even more?
No, that's worse.
No, that's worse. All right, let's go back to the sweet spot. So right in here,
Okay.
are you seeing pretty well?
Yeah.
Okay, and then we could repeat that with the other side.
Yeah.
And then you take off the glasses, and there's a number
Yeah.
on that lens, on this ladder of lenses
And
that you
we-
then...
I'll let you read.
So this
Doctor.
Maybe
number
say 2
is
or-
a 1, and the other side is a 2. We did that
Yeah, we did it
prior.
earlier.
And so then you go to the lens set that's numbered according to a 1 white and a 2 white, and you pop them into glasses so that
Yep.
our patient can put them on. And how do you see?
It's perfect. So very easy to do
Very
this.
easy. And so again, lenses like these do not provide a correction for astigmatism or bifocals, but they would, although you could use it to test a reading distance for
Yeah,
readers.
you could.
Although normally just go by age probably in that.
For those who can't see this, it looks similar to prism bars.
Yeah.
Like just vertical bars that you can just
And dial them up and down.
And it's
Dial up
called
and down.
Global Vision 2020.
Okay. So
That's
tools
the-
like this allow us to help patients with their optical needs in settings that wouldn't normally be difficult to bring a lot of equipment
Right,
to
right.
them.
So it's the idea of bringing medical care or care to people rather than waiting for them to come. And it's really adapting medicine to people's life circumstances instead of having people adapt
Yep.
to medicine in this
And then
traditional clinical setting.
In that setting, with that sample set of lenses, you have a bunch of frames that you choose that would be some sort of standard size to fit those lenses, and then you pop the lens in and out that you need, and you're able to dispense them right there and then.
Yes.
Okay.
Yeah. We have a children's kit, so the adult kit comes in brown and black frames, and the children's kit has those colors as well as a pink and a blue.
Yeah.
And so we've been able to go to a high school and first and second year medical students have been doing this. Now first year medical students are our team that goes out. And we went to a high school nearby, not in the city, but nearby. And there were students who had failed their eye exam in their high schools. And they came to us and did just like you did, just like the two of you did. And first could see not much on the chart, and then popped out the.
We're able to refine their refraction.
Yes, and then they could see. And so first year medical students could see the non-seeing, and then the actual
that wow
see.
factor is.
Yes.
I'm sure that's it's a core memory, right? Of like, whoa,
Yes.
I just did that, and now the
Yes.
patient has immediate improved quality of life. Of course, like with really high myopia or high astigmatism, this is not going to be effective, and that's clear. We make sure that, and I know you make sure of, if their glasses don't meet their needs, then they need to see an optometrist or an ophthalmologist. So that's very clear. But if immediately they can improve their vision, then that's the goal.
Yeah. We sort of take a harm reduction approach of it's better than nothing. Is it better than nothing?
And I'm sure, as part of this care, whether you're caring for their, understanding on diabetic health, hygiene, and you're talking about foot care, but in this case, I imagine as you're forming these assessments, as much as there are routine optical needs that you have, I imagine, and maybe Brittany can speak to this, there are definitely individuals that have ocular needs that warrant care above and beyond.
For sure. So in the street medicine eye clinic, which is a community clinic that we have 2 or 3 times a year, depending on the year, we see a lot of patients at every clinic, and every patient is offered a dilated exam, a slit lamp exam, and a manifest refraction. We have 4 lanes, quote unquote lanes, where we have 4 opters. And we've had donations of slit lamps. And I think we should talk about that, like donations and who do you partner with and what grants have been written, because it takes a village, right? Not just the volunteers, but the community effort and partnerships is huge. But yes, I, as a retina surgeon, have operated on several patients that have come through these clinics with retinal detachments, macular holes. We've diagnosed tumors. For kids who, come in with significant issues, we've gotten them into even your clinic. It's amazing that
a lot of cataracts.
A lot of cataracts. Yep. And our chief residents have done a lot of cataract surgeries for our community members. So I do want to have you maybe speak to the grants and the partnerships and the efforts that it takes to run a program. So maybe for the people who are listening that are like, I don't know if I can do that in my city, right? Because we don't have it yet. A reminder, we didn't have it a few years ago.
Yeah.
Right?
Yes.
So what did it take to get to this point?
Yeah. It took you.
Well, sure. It does take people who are motivated. And you can reach out to me if you want. I'm happy to help.
And we're creating a manual, right?
Yeah.
Of how to do it. So another reason to contact you too.
Yeah, we're publishing a manual on how to start a street medicine community eye care clinic. So that should be hopefully in print later this year.
Yeah. We learned there's a street medicine team in Pittsburgh that did use the autorefractor that we use in our clinic. And that was our first piece of equipment that we bought. And they didn't have an optometrist. They just had I think he was a family medicine doc who was very interested in serving people. So they used this autorefractor to get people's prescriptions, and then ordered glasses online for people. So that's like the minimum, sort of, in addition to this Global Vision 2020 kit that you could use. We added a lot more to that then. We have funding from United Way that has for our community clinics, our street rounds, and to incorporate people with lived experience of homelessness. And a local Academy of Ophthalmology Foundation. And then other donations to provide. SLR Foundation is a huge, since they provide the no-cost, brand-new prescription eyeglasses. When people need the progressive lenses, we buy them online through Zenni and pay for those with our grant funds. Lots of volunteers, all different kinds of volunteers, so it's exciting if you want to.
It's wonderful to hear the update on how, and just the reflection on where this program has grown to. You know, as you're saying, it started with just an awareness of the need and a step forward, and the more you step forward, realizing the opportunities, as we've talked about in care, for the people the patients that we want to help, but you think about education, you think about collaborations, and now it's continuing to grow with the support that comes in. It's remarkable what kind of effect this can have on our community, but especially on the future physicians that are growing through these programs to have just a better awareness of the opportunity that's there.
Yeah. And the eye clinic, it's our oldest clinic. We've done it, maybe we're coming up on our seventh time of doing it, when we do it the end of May. And it's a model then of how to do any pop-up community clinic. So it was a model for our dermatology, our heart clinic. We're now doing a joint and muscle care clinic. Will be a new one that we do in June. We're looking at a sort of a surgery. We're not doing surgery in the church basement or so, but a surgery education. What does that surgery mean? What does that involve? Because I learned from a guest at one of our clinics, I need cataract surgery. For the surgeon, they do this all the time, but it's my one pair of eyes. And so the significance of that surgery in their lives was much greater than we might realize. And so if we can do a clinic to explain if you need a hernia surgery or you need knees or something, this is what's involved, and this is the care, and this is the body, and sort of providing that familiarity and awareness of it. But it all is based on our Eyecare clinic that you started. So, yeah. So
going back to the medical education, so I'm going to speak a little bit to just kind of learning about the impact. So we did a survey similar to what you were talking about earlier of the medical students, first-year medical students, before and after their experience with street medicine eye care clinic. And what we found, we gave them a quiz. So they had to kind of go through basic ophthalmology information and some cases, and then we did a pre and a post test. But it also had information about like their interest in ophthalmology, their comfort with ophthalmology, both talking about it and being in a clinic and doing some of the basic tasks. Huge increase in comfort level and very significant increase in interest in ophthalmology. And we don't want everyone to be an ophthalmologist, right? That would make the whole healthcare system fail. But we want people to at least know that it's an option and to be excited about it. And I feel like we're doing that. So my question to you, knowing that the process has started here, for those people who are interested in improving medical education generally, but maybe having a huge street medicine program isn't practical, what are some things in the medical education, I don't know, what could be improved? Like what is missing from our traditional medical education that we should make sure all medical students get?
Yeah, yeah. I think it's what came out of our study of the impact of street medicine training is the life circumstances surrounding a patient, and to be curious about that, and to think about how to adapt the medicine they're learning to those life circumstances. And how can you do that? You really want to learn from people. So we partner, for example, with we partner with organizations that can help teach us that, right? So from the guests or the clients that they serve. So we work with Recovery is Happening, a peer recovery organization, to have a panel on addiction and recovery. And that way we're hearing firsthand from people. We have, as part of the street medicine training, the women's shelter comes in and does a simulation on if it's so bad, why doesn't she leave? And really to understand domestic violence and all the decisions that go into situations. And so if you're not here and you want to do things, it's sort of looking to what resources exist already in your community of people that can teach you about differences, and then work together to try to understand.
One thing to mention, which I found really powerful when I started working with you, is that a lot of these education experiences for medical students are not in the classroom, but they're at the warming center or the day center. They're there with the people and where they live and where they are congregating. And I feel like that really, it makes it very meaningful and real. And it's also meeting the people where they are, which I think is respectful.
It's inspiring to think about. I just appreciate both of you sharing the story on that note, because truly healthcare, as we all esteem it to be, would be to understand people better. And as you're saying, meet people where they are and listen. And what a phenomenal opportunity to do this as care providers, but also do it as educators, as you so well communicated.
My very last question, I know we could talk about this for so long, but my last question is like, what gives you hope? And specifically, like in the next 5-10 years, how do you see this program growing, and what are some of your hopes and dreams for this?
Yeah. So for street medicine, I hope we don't have street medicine, because we'd like people to be housed. Although we create these community clinics for people experiencing homelessness. But then once we've created it, we open it up to anybody in the community, because we don't want to spend time screening for eligibility or finding reasons that people can't come to the clinic. We just want to use our volunteer time to really serve the whole community.
And sometimes that means patients or clients who not necessarily are homeless, but maybe are uninsured or underinsured, right?
Or find it hard to go into a big building. Yeah. The chance to be in a more informal setting. We developed our our rural medicine program so that we have the mentality that we don't need to keep people under a bridge in order to have a program and to be able to serve them, that we want people to be housed. And we can still serve our surrounding rural communities. There are still barriers to accessing care, and still a great need to meet people where they are. People that are on the farm who can't leave their animals or their planting, and come in to have their eyes checked or other medical care. If we can go to them and it can be part of their day, then that seems worthy as well. So I think what gives me hope is to have the human-to-human contact, to really, when you meet people on a human-to-human level, it is satisfying. It's mutually beneficial to be always looking for those areas of mutual where everybody is benefiting. And to do it in partnership with people that in our local community, that is very rewarding and fulfilling and sustaining, I think. Yeah.
Well, thank you for sharing your expertise. It's a beautiful story of having a doctorate and experience and research as an anthropologist and providing, amazing care to our region. Thank you for sharing your expertise and for reminding us that medicine and healthcare starts with listening, right? And understanding people better. Truly, it's been an honor to be with you.
Yeah. Thank you.
Yeah.
You can find all episodes of the Mayo Clinic Ophthalmology podcast on our website, YouTube, or on most podcast platforms.
Thank you for listening, and we definitely look forward to sharing more on our next podcast.